Greetings to everyone. My name is Dr. Zinzi Limba. I'm a specialist dermatologist residing in Gqeberha. This presentation is going to be directed at COVID-19 and the skin manifestations seen with the evolution of this disease. It is also to try to assist the clinician to determine whether what is objectively seen in the skin is a true manifestation of COVID-19 or just associated personal protective equipment injuries to the skin. This content slide is going to drive the learning objectives of this overview to determine the cause of the skin manifestation, as well as to highlight the clinical considerations, identify and distinguish the COVID-19 related skin conditions. It is also to highlight and employ the proposed treatment modalities of the distinguished COVID-19 skin-related manifestations. At the end of the talk, we'd also like to enable or able to employ therapeutic considerations of COVID-19 positive and negative individuals. I'd like to pose a challenge to the listeners to make use of the discussion panel so as to explore and to increase the appetite on this focus of therapeutic considerations. A novel coronavirus was identified in the late 2019, rapidly spreading, leading to a global pandemic. In February 2020, the World Health Organization named the disease COVID-19, which simply denotes coronavirus disease 2019. This topic reflects on the uncertainty of skin-related manifestations of COVID-19 in the era of the pandemic. Addressing this uncertainty is necessary, but challenging because there is paucity in literature to which we can base recommendations. Also, probably under-recognized due to the lack of dermatology consultations in this group of patients. Besides the daily updates of COVID-19 with regards to the demographics of the acute respiratory features, I really had to dig deep in literature to find any updates on the geographic distribution and case counts in relation to the skin. The literature reports identified were 115 records, of which 34 publications described just less than 1,000 patients with dermatological conditions. Of these, 15 were case reports, 13 were case series, and 4 were observational prospective studies. Although the timing of cutaneous manifestations of COVID-19 are difficult to ascertain, the frequency ranges from 0.2% to 20% of cases. Of note, personal protective equipment-induced skin injury is commonly occurring, particularly in healthcare workers, and it's on the rise above 90%. There are ongoing updates in multiple registries. This slide gives us links or portals of which any medical professional or specialty can contribute to. The goal is to increase the knowledge of the dermatological manifestations and the impact of coronavirus disease 2019 in patients with dermatological disease. Considering the pathogenesis of the skin manifestations in COVID-19 are ill-defined, the general consensus of the pathophysiology of the coronavirus 19, which is less than 125 nanometers in size, applauds the following proposal depicted in this schematic diagram of this slide. This virus then attaches to the angiotensin converting enzyme 2 receptors, of which from the point of entry into the respiratory cells and the gastrointestinal tract, a cascade of hypercoagulative state, which then results to high rates of venous and arterial thrombotic vasculopathies, which include pulmonary embolism, cerebral ischemic accidents, then evolve into a disseminated intravascular coagulopathy-like event. Of note, in this slide, a biochemical structure of the skin also has the same receptors seen in the above mentioned anatomical sites. It should be also taken into account that a massive inflammatory response to the antigen or the virus, referred to as a cytokine storm, can occur. According to the pre-existing data, we can therefore speculate that cutaneous manifestations in COVID-19 may present in two major groups regarding their pathomechanics. Apart from the above-mentioned mechanistic patterns reflected or highlighted in this slide, patients with COVID-19 are more likely to have an increased risk of adverse drug reactions and interactions of their treatment causing a secondary cutaneous reactions at any point during the course of the disease. Therefore, it is very important to identify these clues that either support a viral cause of clinical patterns or a drug eruption. One of the most striking features of COVID-19 is a wide spectrum of clinical manifestation and outcomes, ranging from an asymptomatic to organ dysfunction to mortality. However, from the skin's perspective, the manifestations vary from those that arise from an active disease of COVID-19, personal protective equipment, and also cutaneous side effects of the therapy, including vaccination. In the dawn of COVID-19, the most inundating clinical presentation was that of erythematous, violaceous, or purpuric macules, which were predominantly seen on fingers, elbows, and toes. The lateral aspect of the feet were commonly affected, and this clinical pattern was referred to as pernio-like or chilblain-like skin eruption. Our understanding of the pathogenesis of these lesions is still under evolution, as I've made mention, though it appears to be primarily the inflammatory process with histological and immunofluorescent findings similar to those seen in idiopathic and autoimmune-related pernio. This slide reflects to us a range or an array of clinical patterns where Cascus et al. Made a classification ranging from areas of erythema with vesicle or pustules, those are the pseudo-chilblain-like lesions, occurring in his report in 19% of the individuals. He further made a classification of a vesicular eruption, urticarial lesions, maculopapular eruptions. Of these eruptions, the maculopapular ones has an overlap with those found in those lesions found in drug-related eruptions, predominantly found in intragenous areas and flexural areas. The pseudo-chilblain pattern frequently appears in the late evolution of the COVID-19 disease, while the rest tend to appear with symptoms of COVID-19. In this slide on the right, we see a reticular, dusky, net-like pattern, which can be extensive, found predominantly in feet and buttocks. This pattern usually manifests with a hypercoagulative sequelae and a patient presenting with pulmonary embolism or ischemic events. This type of clinical pattern also can occur in a more polar or the extreme spectrum of the clinical pattern, where you have vascular occlusion and or leakage of the blood. The clinical pattern that you can see is retiform type of purpura. To simplify the distinction of COVID-19 skin manifestation, we can also put them into two categories: the inflammatory type or the vasculopathic skin presentations. Characteristics associated with the clinical patterns range from the chilblains occurring in the mean age of 23 years, lasting for a mean of 17 days, to vesicular lesions that occur predominantly on the middle-aged individuals, lasting a mean of 10 days. The urticarial and maculopapular lesions occurring in individuals which are more than 50 years of age show very similar patterns of associated findings. Other characteristics depicted in this slide merely show us the characteristic patterns aligned with the severity of COVID-19. On your left, we can see the punio-like lesions, which occur predominantly in asymptomatic patients, mildly ill patients, and on your extreme right, we have the retiform purpura type of clinical pattern occurring mainly in toxic patients. Most of them, 100%, are hospitalized with associated fever, shortness of breath, and an acute respiratory distress type of a syndrome in 82% of the individuals. Skin injury, mechanical friction, dermatitis, and hand contact dermatitis are due to personal protective equipment. Overzealous and routine hand hygiene measures have been reported in majority of healthcare workers who are taking care of individuals who are affected or infected by COVID-19. These healthcare workers usually, as part of their protective equipment, they are wearing N95 masks or equivalent masks for more than 6 hours. The equipment is usually masks, goggles, face shields, gloves that apply pressure and create abrasions, retain moisture, and can injure the nasal bridge, cheeks, forehead, and hands. This slide shows us an array of clinical patterns which are skin conditions related to COVID-19 as a result of personal protective clothing and hand hygiene measures. On your left, you have your irritant contact dermatitis, and on your far right, an occlusive type of acne. The PPE-induced injuries include desquamation, erythema, maceration, fissuring, papules, erosions leading to itching and pain. The new onset or exacerbation of facial dermatosis includes an occlusion acne or a rosacea, also known as mask rosacea. This is likely due to the friction and occlusion, which has been reported quite frequently in literature, of personnel or individuals wearing masks more than 6 hours. How to then minimize or alleviate these manifestations? The practical use of barrier films, use of emollients before and after hand washing is reported to minimize irritant contact dermatitis. The use of barrier films, dressings at pressure points on the PPE during donning minimizes the pressure injuries, particularly on the nasal bridge area. And also cleansing your face may help to reduce the irritation on the face and minimize occlusion, acne, and other irritations. Also being advised is that if the acne persists, the use of topical retinoids can be used on the active lesions on a dry skin surface at night. This will then cause an evolution or resolution of the occlusive acne. Another advised literature is scheduled PPE-free periods within the 6 hours of use. You go into a safe environment where you remove the mask, particularly if it's within 6 hours, cleanse your face to minimize manifestations of the pressure injuries, to minimize manifestations of the occlusive type of acne that usually erupts. However, the effects of these preventative measures of PPE ability to prevent viral spread are not well characterized, and the caution and thus caution is warranted. First of all, it is important to point out the serious cutaneous adverse drug reactions are very rare. The estimated incidence of these cases generally is below 0.3%. So most of the encountered skin reactions are self-limiting. They require little or no therapeutic intervention. Particularly with the vaccination, you may have local reactions that include pain and erythema or redness around the injection sites. However, a large proportion of recipients are expecting these or should expect them, and together with the physician, these are common side effects of any form of vaccine and should be expected. The immunological effects of vaccines lead to altered levels of chemokines, cytokines, and which activate different key players in the innate and the adaptive immune system. This includes T cells, B cells, histiocytes, macrophages, dendritic cells. The skin and the mucosa are boundary surfaces to the environment, and they've harvest a lot of the above mentioned immune cells. And this is hence why the skin and the mucosa are largely affected, or the innate or adaptive immune system is generally activated during vaccination. COVID-19 vaccines as well may evoke a delayed cutaneous type of adverse drug reaction, either de novo or in terms of a flare-up of a pre-existing dermatosis. So in the light of the pandemic and the emerging features of vaccines of SARS-CoV-2 variants, potential side effects of COVID-19 vaccines should not impose an obstacle to the delivery of these powerful tools in the fight against the virus. However, awareness of the rare side effects is necessary for healthcare professionals, particularly dermatologists, who are centrally involved in the diagnosis and treatment of cutaneous adverse drug reactions. They should be prepared to counsel and notify the patients of the frequent minimum side effects that occur. With this slide, therapeutic consideration with the COVID-19 pandemic, it has contributed to the need to adjust aspects of dermatological care. Examples include adjustments in the approach of immunosuppressive treatment, phototherapy, skin cancer treatment, and also routine clinical care. The biologics and immunosuppressive therapies play roles in the management of a wide variety of dermatological diseases, such as psoriasis, atopic dermatitis, and other inflammatory and autoimmune conditions. The risks of these immunomodulatory therapies in relation to COVID-19 remains unclear. There has been a consensus in literature from authors that the immunological or immunosuppressive agents that have a focused immunosuppressive effect, for example, biologics, are preferred compared to those causing generalized immunosuppression, including your cyclosporin, azathioprine, methotrexate. Although it is generally accepted that most patients without COVID-19 who are already taking immunosuppressive drugs for dermatological disease can continue therapy, a more cautious approach is typically taken for patients who have suspected or confirmed COVID-19. These patients are considered, and also those patients who are considering starting a new immunosuppressive therapy, a more cautious approach is also taken. Furthermore, we individualize the patients and assess the risk. We consider patient-specific and disease-specific morbidity and comorbidity. In conclusion, many rashes have been seen in COVID-19 or with the COVID-19 pandemic. However, nothing seems to be pathognomic. Therefore, there is an ongoing responsibility to clearly learn about how the virus affects the skin. I do want to highlight once more that in the light of the ongoing pandemic and the emerging features of vaccines of SARS-CoV-2 variants, potential side effects of COVID-19 vaccine should not impose an obstacle to the delivery of these powerful tools in the fight against the virus. Therefore, awareness of the rare side effects is necessary to healthcare professions. Thank you.